Study group with Mary Hill.
Excuse me. Thank you.
You can sit in on the desk.
Hopefully there's enough. Oh, wow.
Just reserve an auditorium.
Goodness gracious, they're still piling in.
You guys would maybe extra chairs from the inside.
Actually, if you split these desks up, these tables into rows, you'd be better off.
Yeah.
Just split them into rows so then you can have more room.
Yeah.
Just taking up a bunch of space.
Yeah. But then I have to fix it later and everything.
I can help you.
Yeah, but that's okay. I mean, what I just need is people to actually have a seat. So grab a chair. I agree with Tyler. If I would have thought about it in advance, I'm so glad you guys came though. So, but
Most people have ever seen a
and
study
we
group.
can even have
How you
people
use
over
it.
here. And there's more place at the table. You know, I mean, you guys can kind of scoot around.
All right, ladies.
Okay. Okay. So yeah, you'll have to get a chair. So I'm asking that if you've gotten a chair from outside or if you've used a table, that you go ahead and take it back. This is fine. Because I am on the call, I need to call out, and I know I have to be at 6:30, so I'm very limited, when we finish up. So if you don't have a place at the table, why don't you guys scoot it over and
Do you guys want a spot?
Yeah. There should be
Yeah,
some
somewhere to write.
place. There's also a place here. We'll go ahead and
There's
go
no chair.
If you guys scoot it down, you can pull it ahead. No, you're fine.
what I'm going to do to save time, because I want to be able to have an opportunity to do as much as possible, is that even if I don't know your name, I'll point to you and I want you to gather the information for this particular topic. So patient teaching, tuberculosis and pneumonia, obesity, metabolic syndrome, sexuality, and STIs, wound care, and pain. So, patient teaching. So, what I want, if you'll go ahead and look these things up, so assessments made in preparation for patient teaching, types of learning domains, and examples of psychomotor learning. If you're not able to find that, look on the internet, see what you can find, and yeah, go ahead and take a picture of it so you'll have it to refer to, because I'm going to go ahead and go on. So tuberculosis. So next line, I'm going to have you look at the positive TB skin test and the positive TB skin test reading, you know, what it donates, indicates, at the rows, and as well as the induration size. The next person in line, I want them to look at signs and symptoms of TB. Okay, so right here, so signs and symptoms of, yeah, okay, right. So everyone, so yeah, go ahead and just make sure you got it, and you put a thumbs up or something, so I know that somebody got that information. Signs and symptoms of TB, who has that? Okay, so the next would be, and also include the TB that does not respond to treatment. Okay, all right, and the assessment, the next person is assessment for patient with pneumonia. Okay, and we'll put the next person, I'm sorry, the person back here, Jasmine?
Yes.
Okay, so if you'll take, look up information regarding nursing diagnoses for a patient with pneumonia, some of those nursing diagnoses. And then next in line, I want you to do prevention of aspiration pneumonia and complications of pneumonia. Well, go ahead and do prevention for aspiration pneumonia, and then we'll have the next person. You in the black, I'm sorry that I don't know you guys' names.
That's fine. No.
I'm going to have you do complications of pneumonia.
Okay.
Okay, so next in line, BMI. So how is it measured and the criteria for underweight, normal, and overweight and obese. Okay. Next person, we'll talk about testing for body fat composition and medications that are used to assess for weight loss, as well as some of those side effects. Okay. Next in line, we have types of weight loss surgeries and complications regarding the weight loss surgery. Okay. You'll have signs and symptoms of Dumping syndrome, and we're going to go ahead and go on to the next topic, and the definition of sexuality. What they're giving you is the definition of sexuality in your class. Holly, you'll have client education. That went back the wrong way, didn't it? Okay, client education regarding reducing the risk of sexually transmitted infections, and the assessment of the assessment of client risk for STIs. Okay. Examples of STIs discussed in class. We'll go ahead and take that. And some of the key features regarding the transmission of STA discussed in class. So I'm going to have both of you guys work on that. So maybe you can work on, maybe you would take some and she would take some. So you'll have to kind of figure that piece out. Special is consideration for STI treatment. So go ahead, Jolanda. You can go ahead and take a picture of it. So you guys will work on that together. Okay?
Yeah.
Okay? And wound care. So in addition to special considerations for STI treatment, you'll also look at wound healing. So the essential nutrients for wound healing. Okay? So does everybody have an assignment? Okay, I think everybody does. So spend a few minutes kind of trying to get that information, and then we'll move on. We'll have a discussion, and then we will move on from there. There's a signature sheet. Did everyone sign in?
Does anyone have an iPhone charger with them?
I do.
Can I borrow it?
Can you send those now? No. Oh, yeah. And I'll just go through those and stop asking questions on those tonight.
Jasmine, do you want to sit over here? I can move.
Oh, this is.
We can make
I
it.
feel like you guys.
Come on.
You sure?
Come on.
All of this is stuff that we don't
Who's been here before and knows what we're doing?
Have you ever been here?
No?
Oh, yeah.
Mm-hmm. Holly's been here.
All I heard was that I was assigned diagnosing or nursing diagnosis for GP. That's all I heard.
So yeah, that's what I mean. We all just have
all we
a
have to do.
part. Yeah.
For sure I'm missing this one.
I'll get my whole thing spread out.
Well, it went up ahead of what I thought it would. So, I'm actually going to probably, so I'm not moving this too far, sit here so we can have a conversation. So, going to go ahead and go back. Okay, the person who had patient teaching. Let's talk a little bit about patient teaching. So you're going to share with your colleagues, and then anybody else who has something to share, I want you guys to be sharing that now. So the things that you remember from class, that we have in your slide sets. And so we're talking about assessments and preparing for the learning of the patient teaching, types of learning domains, and assessments or examples of psychomotor learning.
So for the assessments made by the nurse in preparation for patient teaching, I got mental status, cognitive level and ability, readiness to and motivation to learn, cultural and language differences and support systems. Types of learning domains, cognitive, affective, and psychomotor. And then examples of psychomotor learning are like taking blood pressure head-to-toe assessments, putting an IV line, mixing insulins in the same syringe and administering sub-Q IM injections.
Okay, and so anybody have anything in addition for assessments? Okay. Did she talk about readiness to learn? You have to look at what other factors are involved with that patient. Do they have unmanaged symptoms? So they wouldn't be ready to learn if they had unmanaged pain or unmanaged anxiety. They may be very anxious about their disease. So that's going to be important to assess, is identifying in that assessment what factors, such as pain, anxiety, or any other physical factors that may preclude the person from actually learning. Okay? Because they have to be ready physically as well as mentally. And of course, having readiness to learn, as well as how would we initiate that? So if it's really going to be patient-driven, how would we go about trying to get the patient to make some decisions about learning? What kind of questions would we ask?
Their daily regimen.
Okay.
You can ask what they already know.
Okay, ask what they already know. The other thing is identifying that they're the owner of this. In other words, what is important to you to learn, what do you know, kind of going through that process of making sure that it's not just the nurse that drives it, but it's that it's patient-centered. And we talked about learning domains and different types of psychomotor learning, such as physical practice, demonstration and return demonstration are very, very helpful when we're working with patients where they actually have to perform a task, okay, such as teaching them how to give their own shots, or, for example, you're teaching a wife how to do wound care for her husband or something like that, okay? Tuberculosis, so who had the next ones on TB and the skin testing?
So for a positive TB skin test indicates I have that you have been exposed to TB or someone with TB. And then for a positive reading and duration size, it should be greater than or equal to 10 millimeters or greater than or equal to 5 milliliters with an immunocompromised person. Okay. And so that positive, it may be latent TB, so active TB is going to show up differently. And so, but if they have that positive, you're right, because it says positive skin test. I didn't see that. So positive skin test would actually could mean active. I misspoke on that. So what would be the things that we would do, and we'll talk a little bit about that. But so there would be what to be done. And whoever had the diagnosis of tuberculosis confirmed by, how about you answer that piece, because that will answer my question.
How do we then
The nursing
confirm?
diagnosis?
Yeah, who had the diagnosis of tuberculosis is confirmed by?
I think it was you.
I mean, I have it.
Okay.
I had only the symptoms though.
Okay.
Not even the symptoms, but it's diagnostic microbiology. So it's the 3 consecutive sputum tests.
Okay, but what is the sputum being tested for?
The antibodies?
The
Okay.
mycobacterium.
Okay, and so you need to look back in your slide sets and your notes regarding what that, some of the ways in which you would see, in a lab, what type of test that would be.
Gram negative?
Okay, so you tell me. You guys look at it. Okay, so it's a gram stain. Okay. It's going to be on a sputum sample. So you're going to want to culture.
Oh, it was the acid
and
fast.
the acid fast bacillus, the stain. Okay, that's going to be that diagnostic test that actually confirms tuberculosis. And you're right, it is also about the 3 positive sputum cultures, but that's what they're culturing. Okay.
Can you say it one more time? I'm sorry.
So it should be in your notes. Go ahead and look back through on the slide sets that the 3 sputum cultures, when they are sent to the lab, they're looking for a gram stain of the acid fast bacillus. And that's how they determine if it's TB. Sure.
You said a positive test for TB means can mean that it's active, but if you have latent, would it still be positive?
It would probably be in that equivocal. So it may or may not be. They could, if they have a larger, like a 10 millimeter thing, that's when they would start to do additional things like the X-ray, and because they need to be confirmed that they're not active TB. Okay. Usually someone who has tested positive for a PPD skin test, once they actually do that and it's known that they don't have TB, they go ahead and will do a chest X-ray in place of the PPD. So signs and symptoms of TB, who have that?
I did. So you'd have weight loss, loss of appetite, a low-grade fever, night sweats, cough, fatigue, and painful breathing, and hemoptysis.
Okay, so you're going to be coughing up blood, they're going to be very tired, they're going to have weight loss. Okay. What about TB that doesn't respond to treatment? There is, especially now, there's more and more tuberculosis that doesn't respond to any treatment. Does anybody know?
Say that again?
Tuberculosis that doesn't respond to treatment. What is that called?
Drug resistant.
Right, drug resistant. So you have different people who have drug resistant tuberculosis that when they get treatment, it doesn't really cure their disease. Okay? What about assessments for patient with pneumonia?
Well, I said I just said their breathing, their breath sounds. You can do the tactile phrenitis. It would increase over if you have consolidation in your lungs. If they have a cough and gag reflex, and if they are coughing, if it's productive or not. If they're using accessory muscles to breathe, if they have dyspnea, chest pain. Their swallowing abilities, if they're at risk for aspiration pneumonia.
So looking at that fast respiratory rate, maybe deep respiratory depth, they're just not getting that good oxygenation.
Yeah.
How will we know that they're not getting good oxygenation?
O2 will be low. They could have cyanosis.
Okay.
Their fingernails might look kind of pale.
Okay. So low saturations and bluish or pale fingernails. Okay.
Confusion, agitation.
Confusion and agitation. And what about a nursing diagnosis for a patient with pneumonia? Nursing.
That was me.
Okay.
I put ineffective breathing patterns, ineffective airway clearance because the sputum could be so much that
Right.
you're not getting it up. Activity intolerance, and then I thought what was important too, because you have such trouble breathing, you might not be able to eat as
Okay,
well. So
right.
you have, I think it's like impaired nutrition, less than body requires, or imbalanced nutrition. That's what
Right.
it is.
And just the fact that they have an infection too increases that caloric need.
Mm-hmm.
What about prevention for aspiration pneumonia?
I said that you should, for patients with loss of consciousness or seizures, they need to be placed on their side. If they've had a head injury or a stroke, because they may have problems with swallowing. If they've been under anesthesia, they might have loss of gag or cough reflex. Or alcohol intake or medications that may be like try to avoid the sedatives or be aware if they are on them.
And it's important to teach the family members about this because family members will oftentimes come in and try to get their loved one to eat or drink, and the patient's not capable of that, and then they have aspiration pneumonia. Usually thin liquids are actually harder to swallow than thickened liquids.
Yeah.
So thin liquids can be a cause of aspiration.
Yeah, I have that. You may need to thicken the foods. And then with tube feedings, the head of the bed should be elevated at least 30 degrees, and then stop the feeding if you need to move them. Ask them if they're experiencing any nausea or fullness, abdominal pain or cramping, which may indicate slow gastric emptying and lead to regurgitation, and measure the residual before you administer a new feeding. Patients that are eating just regular PO, they need to be sitting up 90 degrees, and ask them if they wear dentures.
Great. Those are all great prevention. What about complications of pneumonia?
So pleurisy, pleural effusion, atelectasis, lung abscess, pericarditis, and empyema. I don't know how to pronounce that.
Empyema. Infection.
Yeah, that's that.
And so that fluid accumulation around the lungs is that pleural effusion. How is that treated? So say they have excess fluid in their lung cavities. How do they treat that? So through thoracentesis. So that's actually putting a needle into that area and drawing out the fluid. And so that would be, they actually have these catheters now where if they're having ongoing problems with fluid in their lung and or fluid in their abdominal cavity, that they actually can tap them. Nurses can do that, but that's usually a physician. To do the needle, it has to be a physician. If it's something that's like capped off and you're able to drain it, so usually it's the. So what can the thoracentesis, what can that procedure do? What will happen potentially as a complication? Puncture the lung, okay. So a collapsed lung is called what?
Pneumothorax.
Pneumothorax, okay. So as they're going in, they may go through a different place. So instead of that area around the lung that's filled with fluid, they may actually go all the way through and then actually can collapse the lung. Okay? Okay. So obesity and metabolic syndrome. So let's talk about that.
So your BMI is measured, obviously weight over height squared times 703. If you're underweight, it's going to be 18.5. Normal is 18.5 to 25. Overweight is 25 to 29.9. There's upper body obesity and lower body obesity. So if the hip ratio is greater than 1 in men, that's upper body obesity. If it's greater than 0.8 in women, that's upper body obesity. That's going to be apple shaped. And then the pear shape is the lower body obesity, and that's a hip ratio of less than 0.8.
Okay, so who has, so normal, if we think about, if we're looking at what we're expecting normal to be, which is around 24,
Right.
then you kind of gauge it on either side what that could be. Like, is it close to 24 on the overside, or is it under 24, and then, you know, if it's way over 24, then we'd be looking at the obese category. Okay, testing for body fat composition. Did anyone have that?
Yeah, I don't know what that means. I didn't realize that I had that. I did the
Okay.
meds, but what do you mean by that?
Okay, so
That's not
there's
like the
ways
pear-shaped
that
and
you
the-
can test. Did you guys not? So calipers.
I was up at like underwater thing.
Okay, so then the underwater thing is called what?
Hydrodensitometry.
Okay. So going under the water and doing, there's a special test doing the calipers for body fat composition. That may not be real accurate, but can show some body fat composition.
I don't think we got that one.
What is that?
I don't think.
Oh, no, they didn't talk about
How
that.
do you spell that?
So go, no, but what I want you to do is go with what's in your slide set, because I don't want to tangle that up. So go ahead.
So diagnostic tests. So you have
Yeah.
BMI, like she said. You have skin folds.
Guys, listen to your colleague here.
She said BMI, and you can also do the waist hip ratio. And then there's the skin folds test, dual energy X-ray, and the hydrodensitometry is the one that she said is most accurate, and that's the underwater one that she showed us a video of. And then they have bioelectrical impedance, when she said it's not very accurate and they don't really use it anymore. And then I guess waist circumference, and that's also used for waist hip ratio.
What did you say about dual?
Yeah, that one.
The dual energy X-ray absorptiometry. I don't have any like note next to that one, but the one that she put the most emphasis was the hydrodensitometry. She said labs don't really tell you, but it tells you how it's affecting the rest of the body. So like comorbidities, but it doesn't really tell you like if we're obese.
Okay, what about medications used to assist with weight loss?
So I made this list, and for me, I organized them where all the actions like that were the same were all together,
Okay.
so that I didn't have to like learn them
Right, and
separately.
what's a common feature? What's one of the more common one and
The action?
Yeah.
So decreased appetite and increased feeling of fullness.
Okay.
For all of those, the one that I drew the arrow down,
Okay.
all of those are the same. And then the only ones that really stick out are the Phentermine and topiramate ER. It's in a release. And that one has pins and needles and changes in sense of smell or taste. And then the Orlistat blocks absorption of fat, so that decreases the absorption of fat-soluble vitamins. That one also has the fecal urgency that she was telling us about, oily spotting and cramps. And then liraglutide slows gastric emptying and increases the feeling of fullness. And a side effect for that one that sticks out is pancreatitis.
How is the phentermine different?
The Phentermine and topiramate, I don't know how to say that. There's two different ones that have Phentermine in them. Well, Phentermine is like one there, and then this one is Phentermine
And I
plus.
could be wrong, but from what I remember, she said just to focus on all of them are an appetite suppressant except for the O one, which is the ally.
Orlistat.
Yeah, because
Yeah,
that was
and that one decreases the absorption of fat-soluble
because they
vitamins.
have like the anal leakage and all
So
that.
it will
Yeah.
help though, as with weight loss, because of that. So not necessarily appetite suppressant, but blocking absorption of the fat.
Right.
So it's important to know that they may have accidents. They may have incontinence, fecal incontinence, and that's why a lot of people stop these things, is because of the side effects. So types of weight loss surgeries. So there's three main types.
They have gastric bypass, which is also called a Roux-en-Y. You have the biliopancreatic with duodenal switch, which is basically creating a smaller stomach and rerouting it so it bypasses where most of your food is absorbed. Then you have adjustable gastric band, where they put a band at the top of your stomach, and it basically makes you so you can't eat more than a certain amount of food without basically throwing it back up.
Right, but it adjusts. The challenge is if people who have weight loss surgeries don't address the emotional needs behind the overeating, it's usually, people will regain the weight, they'll stretch out the, reoccurrence is actually very problematic and more common than I'd like to say. So, but I don't know how much she talked about that piece. It's just sad because people are really wanting the help and then they don't address what caused them to gain all that weight to begin with. What are some of the complications of the surgery?
I have early post-op. You can have DVTs, PEs, bleeding, anastomach leaks, and cardio and pulmonary compromises. Later post-op, the dumping syndrome, diarrhea, dehydration, hypoglycemia, and then you can have vitamin deficiencies after the surgery.
And many of them have to take vitamin supplements for life, like folic acid and that type of thing. So what about the signs and symptoms of dumping syndrome?
For dumping syndrome, I have it was defined as rapid emptying of gastric contents into the small intestine following gastric resection. The signs were 10 to 30 minutes post-perinatal, nausea, vomiting, abdominal fullness and cramping, diarrhea, palpitations, tachycardia, perspiration, weakness, borbigimus, I don't know how to say that, but I looked it up and it means like rumbling and gurgling in the stomach. 1 to 3 hour perinatal hunger and hypoglycemia.
So
signs and symptoms of
right. So with hypoglycemia, they're going to have sweating, they're going to have vomiting, that type of thing.
And then patient education for people with dumping syndrome. You want to tell them to avoid sugar, salt, milk, eat foods high in protein, unsaturated fat, and low carb diet, eat small meals, and avoid consuming fluids with the meals, and take antispasmodics as prescribed.
Okay, that's actually very important to have the fluids separate than the meals, and then be aware of signs and symptoms of hypoglycemia with the dumping syndrome. Okay, sexuality.
So I had the definition of sexuality, and she was emphasizing that it's not only by body appearance, but also by attitudes, feelings, beliefs, and behavior. It's constantly changing and includes how we relate to other people. It's influenced by physiological, psychosocial, religious, and cultural factors, and there is no normal.
So it's very holistic, it's very broad, and it encompasses many aspects of a person. So what about client education regarding reducing the risk of sexually transmitted infections?
I put transmission of most STIs can be prevented by the use of latex condoms. Once infected, some control strategies would be avoid intercourse with infected partners, use protection, and partner notification.
How do you think you would make the person, that's a pretty awkward topic, and that's why a lot of practitioners kind of avoid discussion of sexual issues. But say if you were working in the health department and that was a regular part of your job, what might you have a discussion with if you're doing like a standard, say if you need to do a standard assessment to make that person feel more comfortable. So would you
give them a pamphlet?
Well, but a lot of people can't read, and you're doing an assessment, so you want to get information. So, but you're getting that information, say at a health clinic. Do you think you're going to just ask one person, or if it's like a standard health clinic? So we're not talking about somebody who has symptoms, but say if they're coming in and you're concerned that you want to get a full assessment of their risks for sexually transmitted infections.
Would that be kind of answer that I put for the next one? Is that kind of it?
Yeah, I mean.
Because I put like the 5 keys, and start with screening and assessment.
So screening and assessment, say if you're working at the health department and you're screening young adults, you would have some sort of a screening form where you're asking the same questions to everybody. So then you can make sure that the person doesn't feel singled out by that. Okay? What about, we talked about reducing the risk of STIs, so use of condoms. And let's see here. Examples of STIs discussed in class. So we had 2 people talking about that and key features of those STIs.
So the ones discussed would be the genital herpes, HPV, genital warts, chlamydia, gonorrhea, and syphilis. And I have stuff written down.
I have the key features for herpes. Is caused by the HSV1, which is mouth, and HSV2, which is genital, and is characterized by red vesicles and blisters filled with fluid. For HPV, I have it's most common genital infection in the U.S. and there's an incubation period of 2 to 3 months, and it causes genital warts, and there's no treatment available unless the genital warts are present, and then there's vaccination as well. And also chlamydia, it causes bleeding because of perennial blindness in newborns. It causes permanent damage to the reproductive system of women, and it's 3 times more often in young adults between the ages of 14 and 24 years old. And it's the most commonly reported bacterial STI. And I have gonorrhea, and this one, there's an incubation, is different. For males, it's 3 to 10 days, and for women, it's 10 days. For pathophysiology of gonorrhea, for men, I have inflammation and pain of the testicle tubes, or epididymis, and for women, inflammation of fallopian tube, and inflammation of tissue surrounding the abdominal area. And the manifestation, I have like milky, purulent, senile discharge after women, urinary frequency. And syphilis, the main thing about syphilis is the complex systemic STI, and it can be congenital, and then that's the one that is primary, which is treatable, secondary, skin rash, mucus, patches in oral cavities, and the tertiary, which is not treatable and is deadly. And you showed us those pictures of.
Okay. So some of though that I want you guys to focus in on is how these things are spread and the contagiousness of it. So something like herpes can be spread when there's active lesions, but also the person can have viral shedding and actually spread the disease even when there's no sign of lesions. And so if the person really has a diagnosis of herpes, the partner and the person with herpes, they need to use condoms. The other thing is regarding so treatments. So who had treatments?
Sorry, you can still get it if you use condoms, though, right?
Yeah, potentially, but it lowers your risk. I mean, it would be unrealistic to think, and because herpes is pretty prevalent, that a person with herpes is never going to have sexual relations. That's not, so yeah, there's always a potential for something, but, the best bet is going to be latex condoms. So treatments. Did anybody have treatments?
I have a special consideration for STI treatment.
Okay.
I have the last one.
Okay.
I have needs for abstinence, use of topical acyclovir, use of latex condoms, hand washing, discuss infection with partner. What else? That is what I have.
Okay. So it's important, though, that the person with an STI knows that all the partners have to be treated at the exact same time. because then reoccurrence will happen. And how is something like, so Jolanda talked about acyclovir, so what does that treat? Herpes. Okay. What about something like syphilis? How is that typically treated?
Penicillin G.
Penicillin.
Or doxy if they're allergic to it.
Okay. So you mentioned a mycin. So if a person is allergic to penicillin, which is the typical treatment for syphilis, we shouldn't give anything that has psyllin or anything that has mycin, okay? Because there's a crossover connection there, okay?
So you would give what?
The doxycycline.
No, not, let me see,
She told
That's
us
what she
that.
told us.
okay, go back and see what she's saying. Am I right though? I thought that I was kind of looking some of this stuff up.
No,
I thought it was
specifically
penicillins and
ours.
Oh,
cephalosporins.
okay, so I may be wrong about that.
Have a
So
thought.
she's saying that you can give this, you should not give the psyllins, but you can give the mycins?
She said that you could, if you're allergic to penicillin G, then you give them doxycycline for 14 days.
Okay, so doxycycline.
I was a little confused
What is
too, so
she
it
saying
adds-
about erythromycin?
She just said to give that to people with chlamydia. You can give